Hello and welcome. On behalf of CME Outfitters, I would like to thank you for joining us for today's educational activity titled Signals of Change in the Management of Atopic Dermatitis. This activity is supported by an educational grant from Pfizer. I'm Dr. Jonathan Silverberg. I'm an associate professor of dermatology, director of clinical research and contact dermatitis at the George Washington University School of Medicine and Health Sciences in Washington, D.C. I am joined today by my colleague, Dr. Zelma Chiesa, assistant professor of dermatology in the Department of Dermatology at the University of Pennsylvania Perelman School of Medicine in Philadelphia. Welcome, Zelma.
Thank you.
Also joining me today is Dr. Melinda Gooderum, medical director of the Skin Center for Dermatology and assistant professor in the Department of Medicine at Queen's University and consultant physician in Peterborough Regional Health Center, Ontario, Canada. Welcome, Melinda.
Hi there.
So let me review our first learning objective, which is to apply the clinical tools to establish disease severity to inform treatment decisions in patients with atopic dermatitis. Our second learning objective is to translate the results of safety and efficacy data from recent clinical trials for emerging agents to the treatment of moderate to severe AD. And our third learning objective is to integrate patient preferences and treatment goals into shared decision-making for moderate to severe atopic dermatitis treatment. And now for our first question for you all. Okay, so we're going to come back to those results of the poll a little later in the program. Zelma, can you please start us off with setting the stage about atopic dermatitis? You've spoken in depth about sort of the typical atopic dermatitis patient. Is there a typical AD patient?
Yes, Jonathan, I think that's a great question to get us started on this discussion. I think as many of us in the audience are aware, atopic dermatitis is one of the most common chronic inflammatory skin diseases that we will encounter in our clinical practices. And it's highly prevalent in the pediatric population, which estimates reported as high as 20%, depending on the population being studied. And I think most of us, when we think about the classical patient for atopic dermatitis, we think about our pediatric patients. We think about patients with flexural involvement. But I also think it's important to realize and to be aware that it's a highly prevalent disease in the adult population as well. Again, the prevalence estimates do vary between 3 and 7%, in some cases as high as 10%. And these are patients that may not present with the usual clinical manifestations, right? These may be, they may have different morphologies, for example, maybe more prevalence of nummular eczema. They may also present with different distribution of diseases, not so much in the flexural areas, but maybe more regional eczemas, for example, on the face, the hands, the feet. And it could make the diagnosis not be as easy to spot as maybe a pediatric patient. And I also think it's very important to think about those adult patients that are coming into our clinic saying, I don't have a history of atopic dermatitis as a child. I don't remember this, because it's been reported in the literature that about 1 in 4 adults who report with the diagnosis of atopic dermatitis actually have adult onset disease or report disease during adulthood. And this could be about 30% of all patients that are adults. So I think it's important to recognize that. And why do we want to make sure we do have the correct diagnosis? And it's because atopic dermatitis is a highly impactful disease, right? It's not only the clinical manifestations, but if you think about the impact of the disease, the psychological burden of AD, if we focus on the adult population, we know that these are patients that are more likely to experience depression and anxiety. And if you look at the data from systematic reviews and other meta-analysis, we also see that these are patients that do report higher rates of suicidal ideation as well as suicidal attempts. And this is something that the patient may not share with us if we're not asking them directly. So again, why it's so important to actually make the correct diagnosis and make sure that we're not missing this.
It's interesting to think about the mental health burden, because I think we recognize how big that is, but I think we often don't appreciate just how commonly, some of these different mental health issues can come up in our patients. And I think it's a testament to just that impact on quality of life. And so, Melinda, what can you tell us about the impact of moderate to severe disease that you've seen in the everyday lives of your patients?
It's a great question. I think, as you mentioned, there's like the clear, obvious mental health issues, anxiety, depression, but then there are these other daily things that are affected either directly or indirectly by the mental health issues or by the atopic dermatitis, which we commonly see in our patients. So whether it's, children at school or adults at work, we see a lot of stress. There can be reduced performance at either school or work. We see a lot of lifestyle modification to avoid different activities that may aggravate the condition. And I'll give you one great example. Today, I saw a patient who is on an effective therapy now, and he took up pottery, and he's been spending COVID, doing pottery in his home. And he said to me, I would never have thought about trying pottery before I had my condition under control. He said it would have been a disaster. So, something simple like getting a disease under control can actually change the things you do just for pleasure, for work. It just really makes a huge difference. That the other sort of impact on their life that's quite common is that sleep disturbance that can happen in all of our patients.
Yeah, it's such an excellent point, and I think it even has significance to what we're going to be talking about soon in terms of how we can measure some of this in clinic, because when you ask a patient, how is the atopic dermatitis affecting their lifestyle? I think sometimes the answer we get is almost disingenuous. And I don't mean that in a negative sense, but more of they've spent their life avoiding certain activities because they know that it's going to worsen their disease. And so, you said it perfectly, that there isn't even like a dream of doing certain activities. So to them, it's like, well, that's just their new life. That's their normal. They don't even understand what it means to do something otherwise. And so I think it's super important to recognize, just from a long-term perspective, how this chronic disease can impact the formative years for patients. And I know I want to hear more from your thoughts of quality of life impact, particularly, as we think about also even the adults with atopic dermatitis.
Yeah, I mean, it's things we see every day in our clinic. Like I can tell you stories all day long. But if we look at sort of more of the data, here's a cross-sectional study of over 600 adults with atopic dermatitis. And they reported just an overall, like a worsening of their overall health, both physical and mental. There's certain dissatisfaction with life. I think that stress and they're being held back from so much. With this limited lifestyle. As I mentioned, their daily activities are affected. They report different signs and symptoms, itch, scaling, redness, inflammation. And if you look at their what we call patient-reported outcomes, or their sort of scores of their own impact, you see very severe scores, high levels of itch, low mental health, just a significant impact on the quality of life.
Interesting. And Selma, anything else that we've missed in terms of just sort of setting the stage or in discussing the burden of disease?
I think Melinda touched on some great points there. I think we all have our stories about patients, telling us specific examples of how their life has been impacted by this disease. And I think it's very important that, as physicians, we sometimes focus on that, asking the question about itch, but then missing all these other questions. And again, I think it's important to recognize that patients won't often volunteer this information. We sort of have to pry it from them. And it's important to recognize this disease burden, that we know that this is out there, because otherwise we may not even ask those questions in the first place. And we don't have time to go over all, studies on disease burden, but I think one aspect is also the impact that it also has on other family members, that we don't have time to address that in here in detail, but there are multiple studies showing the impact on sleep loss, on caregivers, how it affects relationships. So those are things to keep in mind. And it's also very important to, and this sort of opens up our discussion of why we need to assess disease severity, because we know that this sort of impact can't be highest among those with more severe or moderate to severe disease.
I completely agree. And I do think it really does help set that stage. I think you said it beautifully. Patients don't necessarily volunteer all of these things, especially when it gets to issues around mental health and around psychosocial distress. There's often this stigma and a fear of talking about it, or almost the sense that maybe that's outside the scope of the skin disease, so they don't bring it up with their dermatologist. And I would argue that for clinicians who are taking care of the skin disease, if you're not asking pointed questions, if you're not really probing and trying to assess these things in a standardized way, you are missing an enormous dimension of what this disease is in terms of severity and burden. So I think now that we've set that stage about the burden of atopic dermatitis, let's move to addressing disease severity. But first we need to understand how to measure disease severity. And so our first learning objective is to apply those clinical tools to establish disease severity to inform treatment decisions in patients with atopic dermatitis. So let's start off this section with a question about the tools we can use to measure disease severity. So Zelma, are tools to measure disease severity in atopic dermatitis just for clinical trials?
That's a great question, and I think it's a question that we're actually still working on, right? I think it's critical that we defined disease severity because that has implications for treatment. And when you think about defining disease severity, I think it's important to keep in mind that most of us probably do it from the physician's perspective, right? But we also need to keep the patient's perspective in mind. The idea of measuring disease severity at baseline gives us a sense of, what our patient is, not only the level of disease severity, but also what they might be going through. And if we have that baseline, and if we do measure this in follow-up visits, we can start to see that change through time, because most of us, we're going to have these patients for a very long time, hopefully, right? We're going to follow that chronicity. And so in terms of tools that can be integrated into practice, I think it's important to understand, first of all, how many tools are out there. And so there are a number of tools that can be used, right? Most of us may be familiar with tools that are used to measure objective disease severity from the clinician's perspective, which include the SCORAD or scoring in atopic dermatitis, the eczema area and severity index, the investigator's global assessment. And these are measures that we might want to know what they are, right? Because they are used in clinical trials. And if we're trying to understand the data from clinical trials and bring that data back into our practice, we need to know what they're measuring. And in the interest of time, we're not going to go into specific, but it's important for us to become familiar with them. There are other tools that can be used that can measure quality of life. So for example, there's the Dermatology Life Quality Index. There's also the Children's Dermatology Quality of Life Index. And these are tools that are readily available that we can incorporate into our practice. I, for example, use the POEM score, or the patient-oriented eczema measure. It's something that I've been able to incorporate in my practice with my staff, and it helps me track disease severity through time from the patient's perspective, and we'll discuss that a little bit later on. There are other tools that can be used to measure symptoms, right? You can measure itch, pain, sleep loss using numerical rating scales. And again, because this is not just having the patient tell us, well, are you itchy or not, but actually getting a sense of how bad they are, right? It's not the same to, someone saying, oh, I'm always itchy, but my itchy is maybe a 2 out of 10, versus someone saying, I'm always itchy and my itch is a 10 out of 10, and I cannot sleep, at all. And then there are other measures that can be considered for use in clinical practice, which include the Hospital Anxiety and Depression Scale, as well as the patient health questionnaires. I think it's important to understand at least the current guidelines from the American Academy of Dermatology really do not recommend yet incorporating these into our daily routine practice. But I find that in my personal experience, at least having a measure of objective disease severity, something as straightforward as the investigator's global assessment that I built into my, medical record smart phrase, and I have it with me as soon as I open the patient encounter, and then incorporating the POEM score that can be done, at the beginning of the visit, as soon as the patient checks in, actually helps me better understand disease severity. And I think I would encourage other clinicians out there who are caring for these types of patients to try to think about how you can start incorporating these into your clinical practice to measure how disease severity changes through time, because it will have implications for treatment and it can impact treatment decisions.
I agree completely, and I'll just speak to my own personal experience with this. So I measure a lot of things in clinical practice now, and I didn't initially. when I got out of residency, I think I had the same sort of approach that many of us as clinicians do. And I put a patient on cyclosporin, and I'd see them back and follow up, and I say, "Oh, you look so much better," and they'll be like, "Really?" Because I don't feel better at all. And then I realized, because I prescribed it, I assumed, therefore, the patient got better. But in fact, I wasn't using any kind of standardized approach. I had no way of really knowing if they were getting better. And so I said, I need a better way to track this. Like, I need to know how they're doing pre and post treatment to really understand how my treatment works. And I found out that I was just wrong half the time if I was just making these guesstimates separated by 4 months and assuming that the treatment was just making everything better. And so, I completely agree with the importance of this. I actually find that assessing this really makes me faster in clinic, because to ask these as open-ended questions is a nightmare, right? You could spend an hour asking these as open-ended questions, but when you have structured questionnaires that are feasible, and they do it before the visit starts, and you have all that rich information at your fingertips, the visit flies because you know how bad the patient really is. You have all that info. And before, I don't want to interrupt the flow, but I think it's totally related. We do have some questions that have come in that are very much pertinent to this. So one question is POEM easy to do in busy practice? And does it ask about mental health as well? Do you administer it, or should, is it the staff or the patient who does? So I think that sets the stage nicely for your next slide.
Yes, and thank you to the audience for that question. So we'll just take a minute to go over the POEM score, which is known as the Patient-Oriented Eczema Measure. So it's a series of 7 questions, and it's basically trying to understand, what your patient has been going through in terms of eczema for the past 7 days. So a patient can choose, 1 of 5 answers. When I ask the question, I ask the patient, over the past weeks, in how many days, for example, has your skin been itchy because of the eczema? And they can say, 0 days, 1 to 2, 3 to 4, 5 to 6, or every day. And then that is a score from 0 to 4 with a maximum score of 28. And, the higher the score, the probably more severe disease. And so this is actually something that, I agree with you, Jonathan. When I started seeing patients, I really did not use an objective measure or try to kind of capture, that data. I used a lot of open-ended questions, and it would just derail our conversation oftentimes. And then using something like the POEM, actually created it in a way, if you're familiar with the EPIC electronic medical record, you can actually embed it as a smart phrase into your note. I'm sure you could do this probably with other electronic medical records. If you like to have more of a paper record, this is a resource that's available. It's free of charge. You can download it. I like to do it myself because I like to have that experience with my patient, but I have other colleagues who actually have staff members hand this to their patients as soon as they arrive to clinic. And they're filling out their paperwork. The patient sits, answers the questions, and then when they go in to see the provider, their staff member will basically have already added the scores up. They'll circle around it and say, this is the patient's score. And for me, going back to the question about mental health, so this measure does not really address that, right? It addresses itch, sleep loss. It also addresses other symptoms related to eczema, such as, for example, bleeding, weeping, cracked or dry skin, or flaking skin, but not really mental health. I have found this useful when I'm trying to sort of talk about shared decision making, and we're going to go into that later on. But when I'm trying to explain to my patients, look at your disease severity, right? Some patients may be hesitant to go on systemic therapies, and I ask them these questions, and then it's sort of eye-opening to them. They realize, well, you're right. I haven't been sleeping for the past week, but they never thought about that question before. If you do an open-ended question, most of their times they'll say, yeah, I kind of feel like I'm sleeping okay. But then if you ask them this directly, they'll realize, and it's almost, enlightening for the patient to realize, I'm not sleeping, I'm itchy all day. And then once I have a patient on effective treatment, it also helps me to support why we need to continue that treatment, right? So when a patient comes into clinic, I'll have them, consistently answer the POEM score at each visit. And I'll show them, listen, this is where we started and look at where we are now. This is working. We really do need to stay on this path, right? And some of my patients may come and say, you know what, I'm doing great. I want to come off of therapy. I don't need anything anymore. And I try to take a step back and say, you know what, this is really a chronic disease. You need to think about this long term. How can we maintain this disease control? And I think this is a way for us to show to our patients, what we're doing is working. Let's get you on board. Okay. So Jonathan, I think we've had an interesting discussion so far about how to measure disease severity. I gave my experience a little bit on the POEM score, but from your experience, what do you think are the questions that clinicians should be asking themselves when thinking about, how do I determine if a patient has moderate to severe disease? How do I move forward with this?
Yeah, so it's a great question. It's the art and science of what we do in clinic, right? And the determination of, treatment decision-making and when should we start systemic therapies is really complicated. There's a lot of different sort of schematics and guidelines available to try to answer this question. But one of my favorites, if not the favorite for me, is a consensus statement put out by the International Eczema Council about when to, elevate or step up someone to a systemic therapy in moderate to severe atopic dermatitis. And, really the hallmark of that, right? The foundation is, does the patient have moderate to severe atopic dermatitis, right? Before we can get into all the optimizing topical therapy and making sure we've dealt with all of these other confounding issues, we need to know, does the patient have moderate to severe disease? And it turns out it's not an easy thing to answer because there's a lot of different aspects that factor into, disease severity and disease burden. And so, that's where we have to recognize the importance and the potential value of some of the different tools that are out there. And, there's a question that came up from the audience about, well, how many of these different tools should I use? And so maybe I can give you a little bit of a glimpse of that on our next slide. But the first thing to really recognize is there is no single measure that captures all aspects of the disease. And we're not just talking about a patient-reported outcome. There's no single any measure, right? There's no clinician-reported outcome. This is a complex disease with a variable, physical manifestation and symptom manifestation. And really, there really is a need for thinking about multiple different domains of assessment in clinical practice. Now, and you addressed some of these already, but there are validated atopic dermatitis severity assessments like the patient-oriented SCORAD as well. The PO SCORAD is meant to be the patient-reported outcome equivalent of the SCORAD, which is used very much throughout Europe. And the DLQI, the Dermatology Life Quality Index, sort of our gold standard in dermatology for quality of life assessments. Numeric rating scale of itch. It's a single item. It takes like 10 seconds to do to understand how bad their itch was, perhaps in the past 7 days or so. And then a patient-reported global severity of atopic dermatitis. So, as simple as it sounds, just ask the patient, how do you feel your disease is? Is it mild, moderate, severe, clear? And that's important. The patient knows exactly what their experience is. And sometimes what we think is severe is not what the patient thinks is severe, because maybe they have more itch than we can visualize. And so when thinking about well, do I do all of these? I don't know if you have to do all of these, but you have to recognize that they're different and they are capturing different aspects. They'll all be somewhat correlated, right? A DLQI score should correlate pretty well with an NRS itch and pretty well with a POEM, but none of them really fully tell you about all aspects of the disease. So, I could see a very feasible outcome set in clinical practice where we could use the POEM. Maybe a POEM takes about a minute and a half to do on average. DLQI is about the same, about a minute and a half, 2 minutes to complete. An NRSH is like 10 seconds. And a patient-reported global severity is about 10 seconds. So in 3 minutes, you could assess all 4 of these domains potentially, all validated, all giving you important information. And how much richer will your ability to really gauge how bad the patient is doing, how much richer is that going to be with the incorporation of these? I like PO score. It's a little bit more cumbersome for clinical practice. It's the kind of thing that, you do need an app to complete. You wouldn't want that on paper, but all of the other ones could be done paper short forms. As you mentioned, Zelma, can be done as part of the, any EHR built in as templates and things like that. So we have a lot of different options to think about with this. But I would encourage, start thinking about what would fit into your workflow. Do they spend enough time in the waiting area? You could just have them complete it there. If you have the ability to have them complete before the visit, even better, let them do it at home the night before. Then you don't have to waste any time in the waiting area. Right? So you have a lot of different options, but you have to start thinking creatively and see the value of why you should measure. And then you can really find that feasible way to build into practice. Now, along these lines, Zelma, you had led a quality of life improvement project in 2019 with CME Outfitters that looked at using assessment tools in practice. Did you find that clinicians were on board, or did they have to take them, kicking and screaming, so to speak?
Yes, Jonathan. Yes, I did have the opportunity to collaborate with CME Outfitters in this study. And basically, we were trying to understand, well, how, going back to the questions that you were talking about, we have to figure out how we can maybe try to fit these things into our practice. And it will probably, what I do is probably very different from what you do, but at least thinking about what is important to measure. And so the idea was to see, well, what if we just reach out to community dermatologists and ask them, this is the poem score, after an educational intervention, teaching how to use this. Let's see how many of them are currently using this. And we found that first of all, it was a very small sample size. And we found that only about 13% of clinicians at the start of the intervention were actually really using this. And most of them were really not using that in more than half of their patients. And, as you can see here from one of the comments from one of the participants, some providers were a little bit hesitant to use this in the beginning because it's understandable, right? We all have very busy clinical practices. We have patients that are complicated. We really do want to take the time to be with our patients. And we often find that we are running behind, right? And then to have someone come and say, oh, you need to do this now, it could, there, I would say it's normal to expect some level of pushback. But what actually this study found, even though it was a very small sample size, was that, once providers understood what the purpose was of using POEM, what we were trying to accomplish, what we found was that they actually found it quite useful, with almost 100% continuing to use it 3 months post-intervention. And you can see that from, some of the comments that we received from our participants was that it was actually eye-opening for many of them because they were getting a window into how their patient was coping with the disease that they had no idea what was going on. And so this is a way, again, that we can address that. So I think it should be, another push to try to incorporate this as part of your visit. And how you just said it, Jonathan, maybe sending this, now we're doing a lot of telehealth, maybe sending this the day before, or, just having complete this in the waiting room. So again, I don't think that there's one specific instrument that we can recommend at this time, but thinking about maybe what are those that would fit into our practice, right? Not to slow us down, but to give us more information about how can we improve patient care.
So actually, I don't mean to interrupt. One question that has come up, I think it's an excellent question along these slides, is, are certain tools better for pediatric patients with atopic dermatitis than perhaps adults?
So in my particular experience, the vast majority of my patient population are adults, but there are pediatric versions of the POEM score that can be used. There are, in terms of if we're thinking about impact on quality of life, there are versions, like we previously mentioned, of the Children's Dermatology Life Quality Index that can be used. So you have different variations that you can use in your population depending on the age of the patient.
Absolutely. And I think before we go forward, Melinda, I'm curious, what is the Canadian experience in terms of using some of the different tools in clinical practice? Is this something that, is gaining, you feel like, greater attention, or it's still sort of new to clinicians?
Yeah, there's been, I mean, with the psoriasis sort of biologic treatments, where people are more used to doing a DLQI. I mean, we have to do that for insurance purposes. So DLQI is a common one. The poem hasn't really caught on yet, but that's because we're not required to do it for a lot of things. I think, moving forward, if we can do a little more education. And as you point out, it only takes another minute, and that minute can be done before they're even, in the exam room. So we can sort of maybe do a quality control project like you did to sort of show the benefit.
Now let's switch to our second learning objective, which is to translate the results of safety and efficacy data from recent clinical trials for emerging agents to the treatment of moderate to severe disease. So I guess to start us off, Melinda, let's set the stage for this section with a baseline definition of our goals for treatment.
Yeah, I think the ultimate goal is to get control of the disease. So we want to be in a state where there's either no or mild symptoms with a minimal impact on the quality of life. Like, we want to be controlling the disease. We don't want the disease controlling the life of our patient. So once we can get that disease under control, then we want to keep it there. And we want to decrease the frequency of flares, the duration of flares, the level of the flare. So, because this is a waxing and waning condition, there will be flares along the way. We want to be able to get control of them quickly and effectively. And we also have to keep in mind that each patient may have a slightly different goal. They may have different needs. Some patients may suffer from more itch. Others may suffer from more inflammation or skin involvement in very visible areas like the face, neck, or hands. So we have to sort of, model our treatment plan around their specific goals. But I think regardless of the patient, the level of severity, what their specific needs are, we need to identify it early and be somewhat aggressive in our treatment so that we can get that control early and keep it there.
When you're thinking about treatment, is there a specific pathway that you prefer to follow or think we should be following?
Yeah, no, you mentioned earlier about sort of stepping up therapy, and I always like this way. Sometimes I describe it to a patient, it's almost like climbing a ladder. You start sort of at the bottom and you move your way up. And again, as I mentioned, this is a waxing and waning condition, and what may be working at one point may not always be working, and you have to step up therapy with time. So starting with just basic skincare, the use of emollients, we need to rebuild that barrier. That's that's something that's always reminded to patients at every visit. And we would move on to topical anti-inflammatory therapy. And in patients with milder disease, this may be all that they need. But often what happens in patients with moderate to severe disease, the topical therapy is not enough. And I mean, I think we hear over and over about the number of creams they have in their cupboard, or they come in with bags full of what they've been using, and then you realize, that 5th, 6th, 7th, 8th, 9th cream, really, that should have been moved on to something else. And so the fact that we have more options, this makes that ladder a bit easier to climb.
I had one comment, Jonathan, to Melinda's point. When we get to that point where it's the 7th, 8th, or 9th cream that this patient has been prescribed, that, probably is the time where we really want to, really should have maybe consider moving on to phototherapy or systemic therapy. And, phototherapy, I think it's a reasonable alternative if you have it close by and it's available, right? And I think some of the issues that I have with some patients is that they have to drive 2 to 3 hours to come and see us. And because there are no other dermatologists close by.
So where was I? Yeah, using the immunosuppressants off label, but we all do it. And then in the rescue situation, it's the only time I would use an oral or injectable steroid. I really very much try to avoid using corticosteroids in these patients. Sometimes it's necessary. But the last point I wanted to make about this is that we need to actually, once we prescribe these things, we need to monitor them. So seeing patients, depending on the agent that I'm using, every 4 to 8 weeks to see how it's going. In the time of COVID, things are sometimes done virtually. Sometimes it's actually easy to catch up with someone in 4 weeks just to touch base and see how they're doing. If things aren't going well, we bring them in the office. If they are going well, we'll continue on with what we're doing. But it's that sort of maintaining that contact with the patient to be able to follow them.
Yeah, I completely agree. And, something that Zelma was mentioning was just some of the, with phototherapy, can certainly be a good option, but access can really be such a big challenge. Even in the metropolitan areas, there's just sometimes so few providers available. They're not taking new patients. Parking is a nightmare. They're only available certain hours of the day. And then you go to like rural areas and there's literally nobody. So, what might be a good option just may not be a feasible one and an accessible one for so many patients. So obviously that fits into that whole broader shared decision-making. If they can't comply with the schedule, then it's not the right treatment for them. Certainly very, very important options. We do have a number of questions related to therapy, and I'm not going to ignore them, but I just feel like it may make sense for us to get a little further down into our discussion of the specific ones, because we'll tackle probably some of these naturally. Maybe since we started with phototherapy, and I'm not sure if we're going to be talking about it too much afterwards, there is one question of what is the data on phototherapy, particularly in moderate disease? I know we don't have it on the slides, but really just speaking to your own experience to this.
Yeah, I find, it does help with the itch for some patients. To this day, I've never been able to get someone completely controlled with just phototherapy. We have narrowband UVB in my office. And, there are some patients that find it helpful. I also, during pregnancy, that's another safe time that I use phototherapy. If someone has to come off their systemic medication or they don't want to use other things, we use phototherapy. But I find in combination with other things, we can get some control. It's it doesn't work as well as in some other conditions, but it's always nice to have that option, especially, there's a mall behind my office and some people who work in the mall will come over on their lunch hour for treatment, that sort of thing. It's kind of one of those situational things where if it works, it can be helpful, but it's really not suitable for many.
Yeah, agreed. And I think the question is actually, there's a nuance in the question, which was specifically in moderate, which almost understands that this is not a great option for severe disease, right? And one of my challenges that I face, and I think the data really support this as well, is for someone with severe disease, narrowband ultraviolet B, which is I think the overwhelming modality used in North America, is pretty slow, right? It's not, there's the data for it as flare treatment is not any good compared to, let's say, if you wanted to use UVA, which is a little faster, maybe broadband UVB, but of course is not as safe. But with narrowband UVB, sometimes it actually causes flares of the eczema because they're hot and sweaty in the chamber, and and it's really uncomfortable for them. So for really severe patients, I don't even think, like I mentioned, it's not even an option. But I do think for the moderates, it really could be effective. I think the challenge that comes up, and it's really part of our conversation earlier about how do we measure severe disease and moderate to severe disease. I see moderate patients just going untreated most of the time. Like they're stuck in that topical purgatory of like 9-10 topical treatments in a row. And sometimes I think as clinicians, we fail to recognize just how burdensome it is to the patient, because it's not the worst of the worst. It's sort of more than mild, but we don't realize, what we should be doing for those patients. So anyway, but I think it's a great question, and I think it's very relevant. But thinking about some of the newer stuff that's coming and some of the newer treatment targets, literally, therapeutic targets. Melinda, can you tell us a little bit more about those?
Yeah, that's very exciting time actually for clinicians and patients with atopic dermatitis. And there are some specific key pathways that we want to block, and then there are some other more peripheral pathways that may also be helpful in certain patients. So I like to think of it in two ways. Like blocking outside the cell and blocking inside the cell. So when we block the cytokine pathways outside the cell, we can develop monoclonal antibodies that bind to either the cytokines or to the receptors so that the cytokine cannot bind, to block the signal from that way. Or you can develop medications that block the signal inside the cell. And kind of what we'll be talking about today are the JAK inhibitors. And that's basically once the cytokine complexes with the receptors and sends the signal in the cell, phosphorylation leads to activation of the JAK-STAT pathway. And then that signal is transmitted, and whatever further cytokines are made or cell division, whatever the signal is for that cell. And then the JAK inhibitors can block that phosphorylation and thereby block the signal.
Zelma, when we now have a monoclonal antibody, dupilumab, that's available to us, can you tell us a little bit more about the safety and efficacy data specifically for dupilumab?
Sure, and I agree with Melinda. I think that this is a very exciting time for clinicians and patients with atopic dermatitis. I think the more we understand the pathogenesis of the disease, that is actually leading to a paradigm shift in how we are treating these patients. We're not just thinking about treating the acute flares, right? We're thinking about treatment long-term. And that is very exciting, right? We don't just have to depend on oral prednisone to get our patients under control. And, that was the norm for many decades, and I still see a lot of patients coming in saying, I get 3, 4, 5 courses of prednisone during the year. That is terrible. That is not a good long-term plan, because we all know the side effects that are associated with long-term prednisone use. And you're right, dupilumab is a human monoclonal antibody. It was initially approved in 2017 for adults with moderate to severe disease. Currently, it's approved for children as young as 6 for the indication of treatment of atopic dermatitis, at least in the United States. It's an injectable medication. It's injected subcutaneously, and it does target the interleukin-4 alpha receptor subunit, thereby inhibiting the action of interleukin-4 and interleukin-13, and helping, which are key cytokines in the inflammatory pathway of atopic dermatitis. And what we're looking here is the data for the Liberty AD Chronos study. So there are multiple studies that have evaluated the clinical safety and efficacy of dupilumab. This particular study is helpful because it does demonstrate long-term data on safety and efficacy. And if you look here, you can see that the Y bar represents the proportion of patients that achieved an EASI-75 improvement from their baseline. Again, why it's important to become familiar with these types of measures so that we can better interpret what those clinical trial results mean. And then you have on your axis, the number of weeks of treatment. And you can see that very early on, there's separation between the curves as early as 2 weeks. So the curve on the bottom line represents patients that were treated with placebo in addition to mid-potency topical corticosteroids as needed. And then the lines on top are various doses for dupilumab regimens. It's 30 milligrams subcutaneously, either every 2 weeks as represented by the green line, or every week as represented by the red line. In these cases, patients were also allowed to use topical corticosteroids of mid-potency. And you can see how that difference is not only separated very early on, but it's sustained across 52 weeks of treatment. And so the outcome again here being 75% improvement in EASI score at week 52 or 1 year. And you can see that about 64 to 65% of patients who were treated with dupilumab did achieve that outcome, compared to 22% in the placebo population. And I think this is very useful because it's sort of what we would be doing in real life, right? Most of us will probably not be treating patients with a systemic agent and not using a topical, right? The goal is to eventually get them control so that they don't have to use them. But I think in real life, most of our patients will be on a topical and a systemic agent at the same time. And what's also important is to show that, we might still have patients that don't respond as well in the beginning, but then they achieve that level of response, and that response can be sustained. And then when we talk about the safety of dupilumab, I think for those of us who use this a lot in our clinical practice, I think most would agree that it's a pretty safe option overall. When you think about, the side effects of other systemic agents, such as, methotrexate or cyclosporine, azathioprine, or mycophenolate mofetil. And there is data for up to 3 years showing that in addition to having sustained efficacy, that it does have a favorable safety profile. So that is actually very powerful for our patients, because, when I start a patient on treatment, most of them will say, well, how long do I need to be on this? How safe is this? And when I have this data, I can show it to them and say, you know what, we do have data for up to 3 years showing that this is safe, that we can continue on treatment. And that is very reassuring, at least for my patient population. In terms of the, treatment emergent adverse events, or we could call them the common adverse events that have been discussed in clinical trials, the most common ones that were reported include things such as nasopharyngitis, headaches, oral herpes, injection site reactions, and also conjunctivitis. At least in my personal, and this is my biased experience of treating patients with this, the most common adverse reactions that I tend to experience or manage in my patient population are either injection site reactions or conjunctivitis. I think it's important to understand that, most of these adverse events were mild, and in some cases did not really necessitate discontinuation of treatment. So if it happens, it doesn't necessarily mean that you need to take your patient off of it. You do need to address the disease severity and possibly consider, what interventions, can be done. So for example, in the case of conjunctivitis, most cases are mild and they could be potentially managed. If it's an allergic type of conjunctivitis, could potentially be managed with over-the-counter refresher eye drops. However, if a patient is presenting with more severe symptoms, I would recommend reaching out to our colleagues in ophthalmology for guidance. I think it's important to know that, while this medication has been proven to be safe and efficacious, there is still an unmet need. And you sort of talked about this before, Melinda, when you talked about the JAK inhibitors, right? It's opening the door for more treatment options that we can offer our patients. So again, a very exciting time for our community.
Great. And there's a couple of questions I think that are clarifying questions that can be useful, I think, before we move forward. One is just to clarify what EASI-75 measures for the audience.
Of course. So thank you again for that question. So EASI-75, basically what it's measuring is from that patient's particular baseline score. So a patient comes into the clinical trial, they come for their baseline visit, we calculate their EASI score. And what this is measuring is a 75% improvement in that EASI score from baseline. I hope that answers your question.
And then I think also, just for context, we had done a study trying to understand what's the best way to interpret improvements of EASI scores, and it was published in the British Journal of Dermatology. And so at EASI, the sort of the minimal clinically important difference for EASI score is about an EASI 50. And that's like a 1 grade improvement in patient-reported global severity, or 1 grade improvement, I should say, in physician global severity, and like a 1 to 2 grade improvement in patient-reported severity. When you get to an EASI-75, that already is more of like a 2 grade improvement in physician severity and patient severity. So it's sort of like a moderate clinical difference. And then like an EASI-90 would be like a really big, clinical difference. So just to give you that context, it's a nice endpoint, but it certainly, we could get better. And there are patients who might be happy with even less. So just hopefully that provides a little additional context. I think one other question also that's relevant here before we move on to the emerging therapies is, if you see some response, but not total clearance by week 10 or 11, do you continue? Do you add another agent or switch? And if you continue, when do you decide you need to make a change? Is that week 16, week 18, or something else?
I'm happy to start the discussion on this question. I think this is a great question that we encounter in clinic pretty frequently. I mean, I think it just depends a lot on who is the patient, right? For example, I have patients who present with very severe, thick plaques and a lot of lichenification, a lot of skin thickening. And, when I talk to patients, I've had patients that we've actually pushed this out almost 16 weeks, almost 24 weeks out. And it took us a while to get there. And what I do, my personal, what I follow, my clinical approach is, as long as my patient is experiencing a form of improvement, and this goes back to Melinda's when you were talking about this time contingent approach about seeing our patients a little bit more frequently, every four weeks, every 6 weeks, to pay attention to those subtle changes. I do that in my practice because a patient, it gives me a sense of, okay, that we are moving slowly, but always moving forward. That's what I tell my patients. And if they are continuously seeing improvement in their itching, if they are continuously seeing if I'm seeing improvements in the inflammatory signs of the disease, the plaques are flatter, there's not as much lichenification, the fissures are closing, then I will continue to push this out. So I don't think that there's one simple, one answer for all your patients. I think you just have to see what your patient is comfortable with doing. What are you comfortable with doing? And if you are seeing an improvement, I would continue to try to push this a little bit farther out. That at least is my personal experience.
Yeah, and I agree. I think, right now, there's one option, right? I mean, if you want to stay on label, you have one option right now. So for patients, the question says, well, like, how long should you wait for them to clear? They may never fully clear, right? The best they may get is an easy 75. And, they're happy, they're doing well, but they're not clear. There's no evidence of remission in those patients. And so, I think now when you have limited options, patients, what choice do you have? You kind of just keep them on it. I think more importantly, it's like, well, when do you decide that it's a treatment failure? Like, when do you decide that there's no response? And that's complicated. But if they don't have improvement, to your point, if they don't have improvement of itch already by 4 weeks, 8 weeks, something's, they're probably not responding. The lesions might not fully clear ever. And to your point, it could take 6 months or more, but at least you should see some benefit when it comes to the itch. And it's kind of arbitrary, but I think already by 4 to 8 weeks already, you can be pretty comfortable. If they haven't had any improvement of itch, it's probably something, maybe rethink the diagnosis, reestablish, go back to the fundamentals, but, they may not do quite so well in the long run either. I think one question that's come up, and it's relevant to both our last aim and to our current aim, which is, are there differences in terms of patients of color? So I'm just going to read through these. One question was, what are the better tools that you would recommend for measuring atopic dermatitis among African-American patients? There's another question of, are the different tools equally effective on people of color with atopic dermatitis? There's some other questions specifically to therapeutics, but I feel like it's, while we're still hot on this topic, I think we should probably address this. What is your thoughts on the tools, and how should we be thinking about assessing the severity of atopic dermatitis holistically in skin of color? Is it the same considerations as everyone else? Should we be stepping up therapy with the same tools, or should we be using different approaches? And maybe I'll open this one up to Melinda first. I know, Zelma, you've done some interesting work on some of this as well. What are your thoughts, Melinda?
I mean, I think probably needs some more research just to prove that, because if you look at the percentages in a lot of the clinical trials, it's disproportionate. And I think that it would be great to have a little more data on that, just to make sure that the tools that we're using are validated in all of the different populations. Where I practice, it's fairly homogeneous populations. So it's not something I encounter on a daily basis. I do find it a bit more challenging to know. And I mean, sometimes I have to ask the patient, is this really inflamed for you?
So I think where we as a field, maybe fail is too strong of a term, but struggle is on the clinician reported outcomes. I think, there's guidance on like how to do an easy score, specifically in skin of color, and upcode the erythema by 1. I think that still fails. I think we're woefully inadequately, tooled to be able to assess erythema and atopic dermatitis variants in skin of color. I just saw a patient today, in follow-up, who is basically erythrodermic, has like 90% BSA with follicular eczema, and was told that they just have some dry skin, right? So, there's things that we can improve, I think, in terms of education and getting comfortable seeing skin of color. But I think even the standardized assessments fail. I love the patient-reported outcomes, particularly for this reason, because, the patient knows exactly how much they're itching, right? I may not be able to fully appreciate the erythema, but they know when they're miserable with sleep loss and itch and pain and everything else. So to me, that's one of the reasons why I find the patient-reported outcomes to be so valuable, because it really does allow for a standardized approach across all patients that really is meaningful. And I agree with your point about the trials as well. We have low representation of underrepresented minorities in the trials. I always question about whether or not I should even trust those baseline severity assessments in the trials for all the reasons I just mentioned. And we do see therapeutic differences in some of these studies based on, background, race, ethnicity. So I think this is an area that really needs so much more work. But I can tell you, as someone who's worked on validating a lot of these different instruments, at the time when we did the studies, I didn't realize how important it was to specifically examine the validity of even the patient-reported outcomes across individual racial ethnic subgroups. We found that they perform relatively similarly, but there's really a dearth of studies that have explored just this fundamental question: can I measure? Should DLQI be the right tool to measure quality of life impact in skin of color? Are they bothered? Are patients bothered equally by the same quality of life concerns? We don't know the answers to a lot of these questions in atopic dermatitis. So I think there's a lot more work needed.
Yeah, I did see a patient this afternoon actually with a darker skin type. And even though his disease was under control, he had a lot of hyperpigmentation. And so that might have that extra impact that I don't know if that's being captured on a lot of these scores.
Right. And it's great. It's a great point about PIH, because in all the clinical trial measures like IGA and EASI, you're taught to exclude hyperpigmentation, right? Because that's not an active sign of disease, but boy, is that bothersome to the patient.
Right. And just one final point on this topic. I agree with you both. I think that there is definitely room for improvement in this area. And when you were talking about the DLQI, Jonathan, I think it's important for the audience to be aware of how this is scored, that there are answers on DLQI that are non-relevant responses, right? That are the value of those answers is equal to being, not important. So there's a potential for underestimating disease severity. So be careful, right? When you're addressing this in your patient population, if there's a lot of non-relevant responses, then maybe that's not the right tool for your population. And with respect to assessing the clinical signs and symptoms of the disease, erythema is very difficult to appreciate if you're not looking for it. So whenever I'm with residents in clinic, I say you really do have to take your time and carefully look at your patient. The patient with the skin of color, the erythema is not as you cannot easily appreciate that. So you have to be careful and not just call this post-inflammatory hyperpigmentation, because you could potentially undertreat your patient. So I agree with you, Jonathan. I think that's where these patient-reported outcome measures are going to be critical, because then we could sort of realize, oh, wait, I'm probably getting this wrong, right? Look at the impact on this patient. So just my little pearl there.
Absolutely. So thank you so much, Zelma. Dupilumab has been our only biologic option, right, for now, but it is likely that in 2021 that will all change, and we're excited about that. So let's turn to talk about some of the emerging agents for atopic dermatitis. We have several agents in phase 3 that are in the pipeline for the FDA approval, and including, so there's a bunch here: abrocitinib, upadacitinib, baricitinib, and tralokinumab. And so we don't have brand names for all of these yet. Maybe a little easier to say those, but start rolling these off your tongue, because these are part of our toolbox very soon. At least we're very optimistic that they will be. And each has, different nuances there in terms of the different therapeutic targets. There are slight nuances between them. Abrocitinib and upadacitinib are both what we would consider more preferentially JAK1 inhibitors. Baricitinib is JAK1, JAK2, so a little difference there. Those are 3 oral options. And then we have tralokinumab, which is an IL-13 inhibitor, as another biologic, as a subcutaneous injection. And I want to emphasize, for those of you who are not following this story, this is not like they just started phase 3. We have publications on their phase 3 data. We are like months or not even weeks away from FDA approval for potentially all of these. So it is really an exciting time. And there's even more in the pipeline, but those are just later stage, or I should say earlier stage. And so we're not going to be touching upon those tonight. But before we go forward into the specifics of the data for each of these individual drugs, we want to start off with an audience response question. Okay, so again, we'll come back to those questions towards the end of the program. So, Melinda, you've seen some of this data firsthand. What can you tell us about the JAK inhibitor abrocitinib for the treatment of atopic dermatitis?
For sure. So abrocitinib, as you mentioned, is a JAK1 selective. So at certain concentrations, it will preferentially inhibit the JAK1 enzyme. But as we know, with all JAK inhibitors, at certain levels, you start to inhibit the other JAK isoforms as well. But when, at the right concentration, when you're getting JAK1, we see some great results. So again, starting out as early as week 2, we see a nice separation from both doses of abrocitinib, 100 milligrams or 200 milligrams from placebo. And we see a very clear dose response over the first 12 weeks of therapy, which is the primary endpoint. With the 200 milligram dose, we get an IgA response, so IgA of clear or almost clear in about 40% of patients. And in the 100 milligram group, about 25 to 30%. So EASI 75, that's 75% reduction in the EASI score from baseline that we talked about. You see just over 60%. So 2/3 of patients reaching that EASI 75 response with the 200 milligram dose, and about just 50% or so with the 100 milligram dose. The other sort of, notable thing about the JAK inhibitors is the rapid reduction in itch that we're seeing, because not only are we, blocking the immune cells with JAK inhibition, but also felt that the neurons who are transmitting the signal may also depend on JAKs. And so we're getting itch in a number of ways. And patients will tell you the itch is, almost instant. The same day they start the therapy, they find a reduction in itch. By the next day, there's a significant reduction in itch. And showing here the PP NRS response, so the peak pruritus NRS, showing at least a 4-point improvement from baseline. You can see at week 12, about almost 60% of patients in the 200 milligram group, and about, almost 50% of patients in the 100 milligram group. So that reduction in itch is really something that's that the patients will notice right away. And we see that sort of maintained over the first 12 weeks. This is looking at the sort of the reduction in the PP-NRS from baseline on that, initial couple of weeks. We can see the daily measures, and you can see that very early reduction in response. Look at that drop in that first couple of days. You can see a significant separation of the patients receiving medication versus those on placebo. So within 24 hours, and you see that continued response in the first month, and then it sort of levels out with that maintained response out to week 12. So as I sort of alluded to earlier when I mentioned that, blocking inside the cell, we're blocking the JAK-STAT pathways. We know that at higher concentrations, we might start to block other JAK isoforms as well. So we really need to watch out for safety with this group of medications. But it's been, great so far to see that we're not seeing any major safety signals with this group of medication. With abrocitinib in particular, we do see some dose responses with some of the adverse events, notably nausea. You see it's highest in the 200 milligram group, However, it's a transient AE. It happens initially with therapy in some patients, but does resolve with time. And again, very low rates of discontinuation because of that. Along with nausea, we do see some vomiting again, higher in the 200 dose group compared to the 100. But again, limited in time, something that resolves for patients. The other sort of notable thing for abrocitinib that we saw that we didn't really see in the other JAK inhibitor studies is a thrombocytopenia. Again, this is dose dependent. We see the nadir at 4 weeks, so there's a drop. But even though patients stayed on medication, there was sort of recovery towards baseline. So there's this initial drop in platelets for some patients with a recovery despite continued therapy. Another one last one is acne that we're seeing with some of the JAK inhibitors. Again, a dose response where we see the highest rates of this sort of acne form eruption, folliculitis in some patients with JAK inhibitors. But overall, very safe. There was in the Jade Mono 2 study, there was one death in a patient with cardiac risk factors who had already been off the medication for a number of weeks.
So the audience already preempted with a question: does abrocitinib have greater efficacy than other systemic treatments like dupilumab? And what is the best dosage? So for whoever posted that question, this is your slide.
Yeah, so we'll be moving on to the Jade Compare study. Although it wasn't a head-to-head study, there were 4 arms. So there was the abrocitinib 200 milligram, abrocitinib 100 milligram, dupilumab per the label dose or placebo. So this actually was presented at this meeting at the Quad AI 2021. So hot off the press results here. But this is the deeper levels of response. So these are the high bars that we want to try to reach for these patients, that unmet need that we talked about earlier, where not every patient may respond to what is being offered already or what's approved. So we see very good, the EASI-90 responses, as you mentioned earlier, are those sort of wow responses with the 200 milligram dose. But half of patients are getting that wow response with EASI-90 improvement. So that's 90% improvement in the EASI score from baseline. Whereas we sort of see a little more same ballpark with the 100 milligram dose with what we're seeing with dupilumab. Little bit of difference in those first 4 weeks where the abrocitinib groups get that EASI-90 response a bit quicker. Dupilumab does catch up over time, week 12, week 16. We see it in the same range as dupilumab. So to sort of answer that question, the 100 milligram dose sort of in the same ballpark as dupilumab, and the 200 sort of kicking it up a notch. Looking at the IgA 0 response. So before I talked about the IgA response rate, which is 0 or 1, if you look at just those patients who are completely clear with an IgA of 0, we're getting about 15% of patients by week 16 with the 200 milligram dose, and about 13% of patients with the 100 milligram dose. Dupilumab's going up and down a bit. I'm not sure what's with that. Not really what we see in practice. It's more level. And then the poem, as we just spent so much time talking about how important that is of a measure. Again, looking at the clinician assessments versus the patient-reported outcome, we're seeing the same pattern here where the 200 milligram dose has a bit higher level of improvement. So a poem of less than 3, which again is a very high bar. 25% of patients, 21 to 25% of patients in the 200 milligram dose, but we're seeing similar rates, anywhere from 10 to 12% in the 100 milligram abrocitinib and dupilumab. So from the clinician reported outcomes, we see similarities between 100 milligrams of abrocitinib and dupilumab. And with the patient reported outcomes, we're seeing the patient's perspective is the same between the 100 milligram dose and dupilumab, with that sort of extra bump with the 200 milligram group.
All right. So there's actually been a lot of questions before we go forward, I think, to our next drug of consideration. Just a lot of questions for you, Melinda, around abrocitinib. So in no particular order, I'll go, has abrocitinib been studied in adolescents?
Yes. So actually, there's another, the Jade Teen poster was another poster presentation at this meeting. So from the sort of 12 to 17 group.
And even within like the mono 1, mono 2, there was adolescents plus
Yes.
adults as well. So we definitely would love to see some more of those data cuts specifically for the adolescent groups. Is there data on abrocitinib and durable response out to 6 months or 1 year?
Well, there's the Jade Extend poster that was presented at the EADV. Everything's virtual now. I can't even think of what country I was in when I saw the presented. But so the Jade Extend, the sort of the caveat with that poster presentation was the extended data was only on the monotherapy group. So those patients who did not require the addition of topical corticosteroid. I have not yet seen the full data set presented, but there was, in those patients who did not require TCS, there was a good maintenance of response throughout that year.
Right. Now, when do you think this drug will be available and at what dose?
That's the that's the $1 million question. I think, well, it's probably going to be different for you guys in the United States compared to us in Canada. I'm assuming within the next 6 months to a year. I'm guessing. I'm hoping. And again, we don't know what dose will be approved, if it's the 100 and 200, or this is all what we're waiting to hear.
Absolutely. And I think this is more of an opinion question, but would you start at 100 and only go up in dose if you don't get clearance, or would you start at 200 and then cool them off and then drop them down to 100?
Yeah, that's always another interesting question. Getting back to that, the patient in front of you, right? So if I have a patient who's on the more severe end, I'm probably going to start with 200 and get control and see how they do, and then maybe back off if we can. Maybe someone who's on the more moderate end, I might start at 100 if I have the choice of both. I think of it in the way as that I prescribe cyclosporin now. Sometimes I hit people hard with a higher dose of cyclosporin just to get that rapid control that I talked about earlier, why it's so important to be aggressive and get control of the disease. But maybe that's not what every patient needs, and maybe that's not what every patient wants either. There may be a little bit of trade-off for nausea with the higher dose. So we have to see, once we get this into our hands to be able to work with our patients, we'll be able to get a better sense of that.
Okay, and then sorry to bother you with all these questions, but I think they're great ones. One last one is, why acne with JAK inhibitors?
That is another excellent question. I think we're still trying to sort that out. It's not your classic acne that you may see with comedones, and some patients may have that as well, but I've seen a lot of just sort of an acneiform type of eruption in some patients. Usually it's easily managed with topical therapy, but we don't yet know the mechanism of what's going on.
Absolutely. Okay. All right. So I'm sure there will be more, and we'll have plenty of time for Q&A, but just to keep us relatively on time, I'm going to take us through some of the data related to upadacitinib, which is another selective or preferential JAK1 inhibitor. So these are data from the monotherapy Measure Up 1 and Measure Up 2 studies, 2 identical phase 3 randomized controlled trials. Dosing here, 2 different doses tested. So there's the highest dose, which is the 30 milligram dose. There's 15 milligrams, which is the lower dose. And then there's the placebo. And so these should be somewhat familiar, but the EASI-75, the eczema, which is a 75% improvement in the eczema area and severity index from baseline at, in this case, the primary efficacy endpoints, which will be week 16. And then also the IGA responses, getting 2-grade improvement or more, getting to clear or almost clear for this validated IGA response. And they had to have a score of moderate or severe to begin with. So they have like a 3-4 point improvement by definition. So for the EASI-75 responses, you really see fairly consistent responses between Measure Up 1 and Measure Up 2, maybe slightly higher efficacy in Measure Up 1, but overall very consistent. The 15 milligram dose in of itself looks great. The 30 milligram dose shows potentially even better differential and a better effect than the than the 15 milligram does for the Easy 75. And but Easy 75 is like a moderate improvement. It's a good response, but it's a moderate improvement. And so maybe there you don't see the greatest differentiation between the two doses. When you get to that IGA clear, almost clear, which is more akin to an Easy 90 response, there you see a little bit of an even better placebo-adjusted delta and an even better delta between the 15 and the 30 milligram dose. So maybe the 15 milligram dose is all you need to get a moderate response, but to get to that deeper response, you potentially need to go to that higher dose. When we shift gears and we look at the safety, overall, the profile here is pretty consistent with what we know about, JAK inhibitors in general, and relatively similar to what you saw just a few slides ago when it came to abrocitinib, but there are some differences between them. So we see here a little bit of a stronger signal for acne with upadacitinib than perhaps what we see with some other of the JAK inhibitors under investigation, and there seems to be a dose response. We see a little bit of a signal for upper respiratory tract infections or nasopharyngitis, although it's kind of consistent with what we see in kind of any studies. But interesting here, there may be a little bit of a signal for headache, but it doesn't appear to be as strong as what you just saw for the abrocitinib data. So, there may be a differentiation between these drugs based on their safety and tolerability profile. There may be a differentiation, of course, based on efficacy too. But I think it's an interesting point, and I see the question pop up, and I set the stage for the question, which is, well, if they're both selective JAK1 inhibitors, why do you see differences between them? I can't tell you I have a clear answer on this based on data or mechanistic data, but I think we know that, within multiple drugs within a class, there can be enough of a difference in terms of how it's binding to its target and metabolism and other effects that really can impact both efficacy responses and safety responses. But at this point, it really is more of a speculative type of question or answer, because we don't really have all of the data just yet as to really where the differentiation is. One thing I just point out also on the safety side before moving on is I just find these always interesting. You have, not surprising, but higher rates of atopic dermatitis flares being reported as an adverse event in the placebo arm compared to the upadacitinib arms, and of course the lowest rates occurring in the highest dose of upadacitinib. And so just keeping in mind that sometimes what is referred to in a trial as an adverse event is really just untreated atopic dermatitis. Now, when moving forward and thinking about some of the other data we've seen recently for upadacitinib, there's really some, one of the important questions that comes up, as was discussed earlier, about using dupilumab with topical steroids. Sort of all of the therapies that we use to date, we tend to use with topical steroids and consider that to be pretty real world. Although some of these data are very interesting because they may change a little bit of the paradigm of how we think about, using some of these drugs. So these are data from the AD Up study. And in the AD Up study, this is one that used topical corticosteroids across all treatment arms. So we're not looking now at monotherapy, but we're looking at combination therapy with topical therapy across all of those different arms. And what you see is that, the same very rapid early onset of response already, for a 4-point improvement of itch, which is considered like a moderate improvement in itch. You already have about 20% of patients who are getting there by week 1. Some patients reporting improvements already by day 1. And, for this improvement, for this score, you see a plateau somewhere around week 4-ish, and it does suggest sort of a durability out to week 16. What's fascinating, and what you don't appreciate from this slide, is when you actually compare the endpoints and the results from the AD Up study compared to the Measure Up 1 and Measure Up 2, the monotherapy studies, at the 30 milligram dose, you really don't see much value of adding on topical corticosteroids. And one of the speculations that many of us have talked about in the field, and it's sort of our own interpretation of the data, is that we may have hit this like max, this ceiling of efficacy that we've never really seen before with a 30 milligram dose, to the point that topical therapy may be actually useless because the drug works that potently. So this is something we'll have to see if the real world data hold up and confirm that. But there may be an additional sort of implicit treatment value here, that the drug works well enough in monotherapy that we don't need to use topical therapy in conjunction. So that is sort of a speculative point and a sort of a carrot that I dangle there. But I'm going to now turn it over to Zelma to discuss our next one, which is baricitinib. And so this is, what do you think about baricitinib in particular as one of the other agents that's being studied in atopic dermatitis?
Thanks, Jonathan. Thanks for setting up the discussion for this. I think it's important that, as you said, both of you have said that this is going to be more treatment options for our patients. And so baricitinib, it's undergone phase 3 clinical trials. And this is the data that we're seeing here for the BREEZE AD1 and AD2 studies. And so these were two parallel randomized placebo-controlled trials where patients were just treated with monotherapy, no use of topical corticosteroids. And what we're seeing here is the different dosing regimens, right? So, and that's, I think, another important piece to keep in mind, that when these medications come out, we're going to have different dosing regimens that we need to become familiar with, to get adjusted to. And so in the case of baricitinib, the dosing regimen that was studied was in both clinical trials was 4 milligrams represented by the red bar, 2 milligrams as represented by the blue line. Baricitinib 1 milligram is represented by the white line, and then your placebo control arm. And you can see here again the outcome of interest being very stringent criteria of achieving that clear to almost clear response by week 16. And again, that is what we want to try and aim for, right, as we move forward with these systemic agents. And so we can see similar response rates between both the BREEZE AD1 and the BREEZE AD2, with patients treated with the higher doses of baricitinib, 4 milligrams, achieving the highest responses in terms of clear or almost clear. There's some discussion as to why the efficacy was a little bit lower in the BREEZE AD2, which is what you're seeing on your right-hand side. And we do know that at baseline, these patients tended to have a little bit of higher proportion of worse IGA scores at baseline. So maybe that could explain that. I think what's also important, and we sort of discussed this with the other JAK inhibitors, is improvements in itch. And with baricitinib in particular as well, with the higher dose of 4 milligrams, we started to see very marked differences in the curves when compared to placebo among patients treated with 4 milligrams by week 1. And then a little bit farther out, but not too far out, meaning week 2 for patients treated with the 2 milligram dose. In addition to that, I think the study also provides additional data. They also did capture information on nighttime awakenings using another assessment scale, and also symptoms related to pain in addition to quality of life. And again, they did see substantial differences between using by week 1 in the 4 milligram arm compared to placebo, and by week 2 for the 2 milligram arm. I think another thing that we're not really seeing in the previous slide is that they also looked at patients who were rescued with topical steroids, and the proportion of patients who achieved clear, almost clear, was a little bit higher in those groups as well. Here we are looking, and again, the proportion of patients who achieved a 75% improvement in their baseline EASI scores. Again, we're seeing similar response rates in both trials, again, with the highest response closer to about 25% at week 16 among those treated with the higher dose of baricitinib. And then moving on to the treatment emergent adverse events, again, pretty similar to what has been previously described for other JAK1 inhibitors. The most common side effects that were reported in this particular studies were upper respiratory tract infections, nasopharyngitis, headaches, and elevations in the creatine phosphokinase or CPK, which were transient and eventually resolved. Really did not see, I think, rates of acne. Herpes simplex was also something that was found to be more prevalent in the BREEZE AD1 study. So again, those are, I think, some of the nuances that we have to keep in mind when thinking about these different agents and, deciding which one we're going to go with. I think it's important to know that in this particular trial, they really did not see, there were no deaths reported, no major adverse cardiovascular events, and no major venous thromboembolism events. And again, a short-term trial, but when thinking about safety versus efficacy, something to think about as well. So again, another treatment option that we could potentially have available for our patients.
So thank you for that excellent description. So I think now we'll switch gears and talk a little bit about one of the other options, one of the newer biologic agents. So Melinda, tralokinumab, a new potential treatment, different, right? This is another injectable agent. Can you tell us a little bit more about this and what some of the outcomes were?
Yeah, absolutely. So, we were outside the cell with dupilumab, then we went inside the cell with JAK inhibitors. Let's move back outside the cell. And so tralokinumab is a monoclonal antibody to the interleukin-13 cytokine. So whereas dupilumab's blocking the receptor, tralokinumab's blocking the actual cytokine. And so you've probably seen a theme with all of these studies. You always have the duplicate monotherapy study. We had mono 1, mono 2, measure up 1, measure up 2, BREEZE 1 and 2, and we have extra 1 and 2. So here we're looking at the extra 1 study. So it's a monotherapy study with tralokinumab over 16 weeks versus placebo, and seeing, sort of similar efficacy rates to what we just saw with baricitinib. I think of them sort of in the same playing field. 16% of patients with an IgA response in the tralokinumab group here, so IgA of 0 or 1, and that's 75% improvement in the EASI score from baseline in about a quarter of patients. So that's in the extra 1 study. And we have the extra 2, so very similar results, but again, a slight difference between the 2 studies, and that can vary based on the severity of the patient, but also in the different regions of the world where the study sites are located. We can see some differences. We also see a higher placebo response rate as well in this study. But about 22% of patients with an IgA response with tralokinumab, and a third of patients reaching an EASI 75 response rate at week 16. The adverse events, we've been looking at them previously in chart form, and here's looking at them in more of a visual way, but you'll see overall, well, as you mentioned, Jonathan, with the atopic dermatitis, flares as an AE captured here, more common in the placebo group compared to the tralokinumab group. And then viral upper respiratory tract infection, again, another trend we sort of see in clinical trials where we see higher rates of these, nasopharyngitis and upper respiratory tract infections. The other sort of AE that was more frequent with tralokinumab versus placebo was conjunctivitis, something we also saw with dupilumab. The rates here possibly a bit lower. It might be too early to tell with these numbers, but anywhere 5-6% with the tralokinumab compared to placebo. And then, of course, with all biologic agents, there's always the risk of injection site reaction, but the rates are fairly low. And all of the other sort of nausea, headache, all of these things are quite low rates in both the tralokinumab and the placebo group. So a very, very favorable safety profile with this medication.
So I think, this is a good opportunity really to reflect, because there's a lot of data we just covered, and it may be kind of new for the audience. So, how do you sort of contextualize all this to both, Melinda, maybe we'll start with Melinda since you just presented the Tralo data, but then also to Zelma, where should we fit all this in our treatment decision-making? Like we're going to have to start thinking about this in like 6 months. So this is like real soon. 4 new options, each a little different, some similar, some different. Like where do we put it all?
Yeah, no, I think that's going to be a very steep learning curve. I mean, I've been using these agents in clinical trials. So I've been fortunate that way that I've been able to, see how they work in my patients. And I appreciate that, other community clinicians will just have all these options, presented to them within months. So, as we've talked about earlier, patients present differently. They have different goals. It's all going to be part of this shared decision making because patients may have their own ideas of what type of treatment they want, whether it's oral or injectable, whether they want to accept any risk of nausea or acne versus conjunctivitis. So, patients are going to have their own preferences that we will have to take into consideration when we make that decision of what therapy we're going to do. And then we have the different doses, as we just had a discussion about. Then it's like, do you start with the high dose and taper down, or do you start with low and move up? So I think it's going to be a very personalized decision or approach with each patient. That's how I foresee it anyway.
And Zelma, what are your thoughts?
I mean, I agree completely with Melinda. I think that this is going to be very personalized. And I think as a clinician, the first step would be, okay, we've just presented a lot of data, take a step back, breathe, and then get familiar with those. I think those pivotal trial data that we just went over, and try to become familiar with not everything, but maybe key aspects, the IGA, the EC75, maybe the adverse event profile, and then start to think about who your patient population is. And I think it's going to vary a lot. And such as Melinda was saying, you may have a patient who prefers an oral agent versus an injectable. You might have a patient who wants to be very aggressive in the beginning. So you're probably going to go with the JAK inhibitors that offer you the higher response rates early on. You might have a patient that's more, wants to take the more cautious approach and maybe use the one that so far has reported less adverse event, and you'll go in that direction. I think it's all part of this process of shared decision making, right? Where we're trying to bring the patient into the conversation. So it's an exciting time. It can also be very overwhelming, but let's take it one step at a time. That would be my first piece of advice.
Great. I think that was an excellent summary, and I think it really it sets the stage very nicely for our next learning objective, which is really to integrate the patient preferences and the treatment goals into shared decision making for moderate to severe disease and treatment, and recognizing no two patients are alike in terms of their severity, no two patients are alike in terms of their preferences, and it's a tall order to really personalize the right treatment to the right patient, but that's the ideal, right? And that's at least something we should be aspiring to. So I think before we dive into some of those broader considerations for treatment, let's do an audience response question. Let's talk about the different considerations for treatment and factors that influence outcomes. And so Zelma, tell us how we can encourage patients to be a part of the ongoing decision-making process.
Right. And so as part of my considerations for treatment as a clinician, my first goal is to treat the acute flares, right? As Melinda was saying, we want rapid control of this disease. That's what I want to do as a clinician. And then I'm thinking at the same time what I'm going to be doing for my patient long term. But another important piece of this puzzle is patient preference. And I think when we're talking about shared decision making, we're thinking about what are the guidelines telling me, what's the data that's out there, what's the review of the evidence, the clinical literature like we just did here today, what is my patient's level of disease burden from my perspective and their perspective, and also looking at the impact on quality of life, how this affects their lifestyle, what are their patient preference, and all those things sort of coming together into, I envision this as a very large pot, there's a stove and you're cooking all these things together. You're trying to come up with what will be your treatment decision for your patient. I think it's important, and we sort of talked about this a little bit, a shared decision making. And it's not just us telling the patient, these are what I think are the options that you should be doing. In a true shared decision making model, this is the process by which both the physician and the patient are trying to come together, and discuss those treatment options that they can arrive in a joint decision. But what's always going to be your guiding principle here is the patient. What is the patient preference? What do they want to achieve? And you have to keep that in mind as you're deciding, which way we are going to go. And so part of that shared decision-making process is educating our patients. And so there is data showing that education probably will not happen during the first visit, right? Your patient will probably leave with questions. You need to see them in follow-up, use maybe that time contingent approach, seeing them in follow-up early on so that you can answer any additional questions that they might have. But I thought it's also very important to take the time to explain what the treatment options are, and not just telling them, this is going to be doing this or that, but what are the side effects? What are you risking? What's the risk versus benefit of doing each treatment intervention, right? Because you want your patient to be able to make an informed decision. And that's very critical as part of the shared decision-making process.
I think these are really excellent points to think about. And boy, I know, I try. I really do. I use the verbiage all the time that I'm trying to practice shared decision making, but it's hard. It's definitely hard to do. I do think that, just bringing back in what we talked about earlier, a lot of the tools that we talked about can assist with that. And we'll talk about some potential solutions. But I think I validate the concern of any clinician out there who's like, oh my gosh, I just want to get in and out of the room as quickly as possible. And I get it when you're running behind already, but it really will elevate, the patient's, care. And I think it makes the patients more engaged. I think we'll get to talk a little bit more about some of the specifics of what some of those patient preferences are. And maybe actually even rather than saving it for later, maybe this is a good place, I think, just to have a little conversation around. We touched sort of when framing this about, some patients like an oral and some patients like an injectable. What are some of the different concerns that, you guys routinely encounter and that you feel is an absolute must for the clinicians in the audience to know about, to really, include and incorporate into that shared decision making?
I think that, as you just mentioned, is the barriers is time, right? So I think you have to really be clear in what you're offering. Maybe use some sort of like handout or something to summarize, because patients don't always remember everything that you go through, and especially if you have 4 new therapies to discuss, maybe having something with the highlights out might actually help move that, keep that visit within the time that you've allotted.
I think in my experience, I find that first initial visit with the patient is probably the longest one. But I find that as the time, I look at it as an investment. I find that, okay, I'm going to invest the time here today to make sure that my patient understands, what having atopic dermatitis means, that it is a chronic disease, that I can't offer a cure, but we're going to do our best to get this under control. And I find that time investment in the beginning saves me time in the future, because we don't have to go over questions, over statements that might have been misinterpreted. It's always good to review, but I find that if you do that first intervention and you take the time to discuss this with patients in the beginning, it does save time early on. And as you mentioned, Melinda, providing some sort of written information for your patients can sometimes also be useful. So that to me is critical, just doing that first investment in the beginning of the visit.
I completely agree at that high level. I think, some other things that, come up, the topical versus stepping up to systemic, I think is such an important issue. We already talked about many patients sort of languish in the world of topicals and never get stepped up. And I think it's important to, our knee-jerk reaction is to offer another topical, is to say, well, is that what you really want? And of course, sometimes just because patients want something that's not good for them doesn't mean, you have to prescribe that. But if they've gone through 10 topicals and they haven't done anything, like, you want to know that. You want to establish, you want to be aligned when the patient says, I'm done, right? I don't even want to go that route. I think the safety and efficacy balance is such an important part of the conversation, especially with some of the newer agents, which are offering premier efficacy, but may come with that safety trade-off. And, every patient, I think, is going to choose differently. And I think it's funny, like sometimes I have these shared decision-making conversations with patients, and I think they're going to go one way and they go the complete opposite direction. And so to me, it just reinforces whenever that happens that, right, patients have their own minds, they have their own preferences. And even if I'm trying to kind of like steer them in one direction, there's going to be something in there that's going to resonate perhaps differently for them. Anyway, and of course, there's so many other nuances to think about, but when we talk, that's a lot to integrate. That's really obviously a lot to integrate in thinking about like, how do you address all that? And I agree, Zelma, trying to get that early on is important. Sometimes though, like I'm in an academic setting and I recognize I have a little more time to spend with patients than in a busy practice setting. And sometimes when it's like the worst of the worst patient, I'll go out of the room. I'll just say, excuse me 1 second. I'll peek out the door and I'll say, tell my medical assistant, do some damage control because this is going to take an hour. Right. And so that's not feasible in all practice settings. But I think, if we don't at least aspire to it, then we're not even going to come close because the barriers will just take hold. So, when thinking about the barriers in particular, Melinda, what are some of those barriers? I know you talked about already time is an important one, but there are other things as well. What else do you encounter as being a major barrier with respect to trying to implement shared decision-making?
Yeah, so I mean, I think some other things are the patient's level of health literacy, like what do they already know about? I have some patients who do all their research online. They're asking me about upadacitinib because they've already read about it, and other patients who just have not gone there and maybe aren't at that level. So you have to know sort of where you're at. And also it's that sometimes patients don't expect, you catch them off guard by asking them like, what are your goals? What do you want? And they kind of look at you like, no one's ever asked them that before. They're just expected you to give them another prescription for another cream. So sometimes the patients are just not ready for that discussion and you might catch them off guard. And in that case, you can always give them something to think about and come back for book a longer appointment next time so you can go over some of that stuff.
I think it's an excellent point. I think, sometimes even a little bit more frequent short visits, right? If you don't have that hour-long slot to offer, well, then maybe bring him back 2 or 3 weeks later so that at least you have the ability to reinforce a little sooner, I think is something also that can help.
Yeah, it gives them time to think about what you discussed.
Absolutely. And so Melinda, can you tell us also a little bit more about just issues related to patient satisfaction and how we can potentially improve that?
Yeah, and getting back to what we've said multiple times, is every patient's different, right? Everyone has different goals. And I think the satisfaction really boils down to what are their needs, what are their goals. And so I've really started doing that more and asking them, what did they want from the beginning? Because they're not going to be satisfied. They're not necessarily going to be satisfied with an IGA of 0 if I haven't met their needs. I may be satisfied when I'm filling out the forms and I'm filling out zeros, but if their issue hasn't been addressed, then that's not going to lead to satisfaction. So you need to establish early on, like, what are their goals? Is there something they're not doing that they want to be doing? Because for them, that may be, they may just need a treatment that allows them to do, take on pottery. Like my patient, he's may not be completely clear, but he can do pottery. And that for him was a win. So he's very satisfied with his treatment, regardless of what his easy score improvement is, regardless of whether he's an IGA responder. So sometimes these sort of things you need to look at for that patient.
It's such an interesting point because I try to, I'll try to tell patients, they'll ask me sometimes like, what are my treatment goals? And I'll always say to them that, for me, you may be happy where you are right now, and we don't have to do anything differently if you are. But, I joke around, I say I'm greedy. I want to get you completely clear and itch free. And that's not always what the patient wants, and maybe I wish they did, right? I feel like I could do more. But, they've lived with this disease for 40 years and they kind of have their own perceptions about it. And so I think it's so important because I can push stepping up doses and tweaking it more. But if they're in the sweet spot and they don't want to do more, they don't want to do more. And so, I think it's just such an important point. We can set all the goals we want, but if it's not really in line with the patients, it might just be overkill. And by definition, it also might be underkill. You look at their skin, the skin looks clear. you think you did a great job, and they're like, yeah, but I'm itching like crazy. I want to sleep more. So, we pat ourselves on the back, but we've totally missed the boat to what matters to the patient. So, one thing also that is just addressed here on the slide is this issue of how dissatisfaction can impact adherence. I think it's such an important point. I tell this to the residents also, especially with patients with like 30 years treatment history. I say you have about 3 days to prove that you're smarter than the last 15 dermatologists, who at this point the patient probably thinks are a bunch of idiots because they gave him the same topical that didn't do much of anything. And so think out of the box, really thinking, understanding what the patient wants and needs, but also recognize speed matters. If nothing else, because if they don't see a quick response, they may just drop it and stop using it. And so I think it's such an important issue that needs to really be addressed. And also, can you tell us a little bit more, Melinda, just about how do we optimize adherence? I mean, because adherence itself is such an important topic.
I think, asking patients right up front, like, what do you not, or what don't you want to do? Because there are some patients who've been using so many topical steroids, giving them another prescription that's not what they want. They're not going to use it. Even if you think it's a better topical, they may have already made up their mind. So again, getting back to that, finding out what their preference is. Getting back to the frequent appointments that we talked about earlier, touching base. And I know that isn't always possible in all the busy clinics, but like I said, during COVID, I'm finding some phone visits just to touch base in between office visits have been very successful. Education, patient workshops. So I know in Europe, they do a lot of these eczema schools that the nurses and dermatologists may have, special classes for patients to better understand the disease and how to care for it. They can be extremely helpful. And then these sort of written action plans have been also proven to be very helpful. You set the goals together and then come up with a plan to address those goals. And then again, they're taking something home with them that they can refer back to, because we know that patients don't remember everything that we've discussed in the visit. So that gives them something to refer to when they get home.
Zelma, we all have our own style and ways that we approach shared decision making. Can you just talk about briefly some of the things that you incorporate into that process, or how you think about that?
So I think we sort of discussed this, so far I think it's been a great discussion in terms of what comes into play with shared decision making. And I think Melinda did raise many interesting points, right? That you want to make sure that your patient takes something with them that they can sort of review and reference, right? When they're at home and they have all their medications and they feel like, I don't remember what I was told to do. And that can lead to the issue of non-adherence, and then that can lead to the being misinterpreted that the treatment is not working. When I have a patient that I know I'm going to go into the discussion of systemics, by the end of my discussion, I see it in my patient's eyes. They are just overwhelmed. So I tell them, you don't have to make a decision today. And I think this is very critical. I say, I'm going to give you this information, because that makes my visit also a little faster, right? Because I say, you know what? I'm going to give you this information. You're going to read about it. We're going to see each other back in about 4 weeks or so, maybe sooner if you would like. And we're going to go over it. Or if you cannot come back in 2 weeks, you're just going to send me a message or give me a call and tell me what you want to move forward with. And my patients will do that. They'll say, okay, I made a decision. Phototherapy is not for me because of these constraints. I want to move with the systemic agent, or thank you, but I want to stay with the topicals for now. Okay, well, then we're going to see each other in X amount of time. So I'm trying to keep the patient engaged in their care. And when they ask me the question, what would you do? As a doctor, what would you do? I always flip the question around and say, no. What would you do? With all this information that I have given you now, if you need time to think about it, it's okay. Go home, sleep on it, give me a call tomorrow or send me a message. But what would you do? That's the critical point in shared decision making. Because I know I'm like you, Jonathan. I'm very greedy. I want to get them clear as quickly as possible. But sometimes patients don't want that. They just want some relief to maybe enjoy the things that they would not normally be able to enjoy, like pottery. So that to me is the main take-home message here is, what does the patient want?
I love it.
And we should base our decisions on that.
I love it. And I love it also that you said, all, give them that choice. Say, you don't have to make the choice now. I try that all the time because I feel like sometimes we're moving so fast, the patient feels like we're forcing them. And so it really gives them the luxury of just slowing it down, thinking about it. So really wonderful insights. So with that, I think now we can really get into some of those SMART goals. So thank you so much, Melinda and Zelma. Great discussion. I just want to summarize 3 SMART goals that are actions you can use in your practice to improve care. 1, measure, 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 right? It only takes a couple of minutes in some of these cases, it takes seconds. Signals of change are coming to the treatment of atopic dermatitis. Know the data well, try to stay up to date. Easier said than done. I mean, it's just a bolus of data right now, but really a lot of effort necessary to improve our prescribing habits and care, and then engaging patients in treatment decision-making to improve satisfaction and outcomes, and recognize that complexity, that heterogeneity of atopic dermatitis, that's going to spill over into very varied treatment preferences, and that we really want to respect that as much as possible. So with that, we have a lot of questions in our remaining just minute or two. We don't have too much time to be able to address all those, but I'll see if we can at least maybe address 1 or 2 questions out there. So one question is, how to do electronic reminders? Can you use apps and things like that? If anyone has any thoughts about that, particularly for the PROs.
Right. I think one thing that we didn't discuss that I was just going to throw out there, and it had nothing to do with the development of this app, but the National Eczema Association came up with an app called Eczema Wise for patients to use that does capture symptoms of itch, and it serves almost like a tracker, so patients can track their symptoms. So if you have patients who are more into this very technology savvy and want something as an app, this could be an option for them to explore.
Great idea. And also, even for like the PO score ad, there's an app, a standalone app available for like a lot of these. There are standalone apps that can be incorporated. Something you can even do is just have it built into your like Epic or into your EHR, where it can just be programmed and just part of your routine workflow. And that's something that I do. You have to have the resources, but it's a great option to think about. And sometimes you can just do paper short forms. So if you're doing them only around your office visits, you don't necessarily need reminders, though the reminders also can be very helpful in terms of, dealing with adherence and stuff like that. Certainly can be very, very helpful. I think there's one quick question, just a theme that has come up in a few other questions. I had hoped that we could address them earlier, and I think we touched upon them, but just, do these different therapies work differently or better in skin of color? And the answer is we don't know yet. We need more post-hocs. We're going to see them coming. I think we're starting to see them being presented now. And I think we're going to need to do more of this comparative effectiveness and safety exercise across all of these new therapeutics. So it's a great question. The data are there. We just need to get a little bit more of a ripe explanation of that and a better understanding of that. So, but I think for the sake of time, since we are at time, I want to really just reinforce, if you have any colleagues who missed today's live program, this webcast will be available on the Dermatology Hub in addition to other resources for clinicians and patients. I would love to thank Dr. Gooderham and Dr. Chiesa for joining me today. Thank you so much for this outstanding program. I also want to thank CME Outfitters for their assistance in developing today's program. I wish we could have all been together, but this is a great virtual platform, and I hope you found it to be very engaging online. I think I know that you did, because the questions have just been pouring in all night, which is wonderful. Stay safe, and thank you again for providing the best care to your patients. Have a wonderful evening.